are those of the participants and do not reflect the views of BronxNet or the program underwriters.
BronxNet. Your voice, your views, your vision.
Good evening. I am Errol Schneer, Bronx Lebanon Hospital Center's Vice President of Planning, Marketing, and Public Relations, your co-host for tonight's HealthBeat television program. We welcome you, our many viewers, and also encourage you to continue participating in the program by calling 718-960-7241 with any questions you may have. That's 718-960-7241. As always, we promise to do our very best to keep you medically informed and healthy by discussing the topics that are of interest to you. Please tune in every Monday evening from 6:30 to 7 p.m. on Channel 67, and you can also find out more information about Bronx Lebanon and its many community services online at our website, bronxcare.org. Tonight, my co-host, Dr. Milton Gums, Bronx Lebanon's Vice President and Medical Director, and I will be continuing our discussion on women's health issues, with a focus this time on the labor and delivery process.
Joining us this evening for what I'm sure will be a most informative discussion are two experts in the field, Dr. Andres Reese, Director of Obstetrics, and Dr. Jonathan Marder, Director of Maternity Services at Bronx Lebanon Women's Health Center. Welcome.
Thank you.
Thank you.
And before we hear from both of you, our panelists, let me once again encourage you, our viewers, to call in with any comments or questions you may have. The number to call is 718-960-7241. That's 718-960-7241. And please call us. Now let me begin the program by asking each of our panelists, and I'll start with you, Dr. Reese, to share with our viewers a general overview of what the labor and delivery process is all about at Bronx Lebanon.
We have to understand that the major goal of our service is to try to make the process of delivering the baby, which is for many patients very dramatic and sometimes also related to some kind of trauma, as uneventful, safe, and sometimes even the patient can remember the process as something what she takes with her with the picture of the baby. And the most important thing probably is to make it safe, to be sure that the mother and the baby are safe during the process, which is, like I mentioned, sometimes could be complicated, and also make it as possible painless, because in the 21st century, people should not deliver in pain. We have our own, independent from the rest of the hospital anesthesia service, which can deliver the anesthesia anytime it's indicated, and can also take care of the patient after delivery to be sure that the pain is controlled properly.
And from your perspective, Dr. Marder, what would you describe as the services?
The services are provided by a full team taking care of each patient. Each patient is assigned a personal nurse, and that person is recognized, and her name is actually placed in the room. And then attending physicians such as Dr. Reese and myself are included in a team with other residents and midwives that participate in caring for the patient and making sure that it is as good as experience as possible.
But before we get to that stage, at what point in time during a pregnancy should pregnant mothers seek people like you out? When should they start coming to you?
A patient is most likely to be prepared for her pregnancy if she comes as soon as she realizes that she's pregnant. We can better offer her early screening techniques and give her a good opportunity to enter the clinic at a proper time.
So what does that mean, proper time? You know, I'm 16. I don't know what's proper time. 16 and pregnant, found out that I'm pregnant today. When do I come?
If you're 6 weeks pregnant,
16.
if you're 16 years old and 6 weeks pregnant, you should be seeking prenatal care from a qualified provider. Yeah.
I would say even the certain category of patients, especially patients with some chronic problems, let's take as example the diabetes, should even enter the process before getting pregnant. Yeah. So they have proper tests done and they knew that they well medically prepared for caring for the baby.
Yeah, but what about sexually active younger people? Shouldn't they be seeing somebody in your clinic at that time also, even before they're pregnant?
I mean, that's, of course, everybody who is sexually active, every female sexually active, should be evaluated by gynecologists on a regular basis to be sure that not only discover the pregnancy early enough, but also to be sure that all the necessary tests are being done.
Because that can make the process smoother at the end.
Absolutely.
Yeah.
Now, Dr. Morta, what do we mean by the term prenatal care? Why is it so important during the pregnancy?
Prenatal care includes the examination of the patient, laboratory examinations, and examination of the fetus as the fetus is growing. It is education for the patient to understand what to expect during the pregnancy and what to expect during the labor and delivery time period. Choices of what to expect and choices as to a birth plan or plans for pain management, even plans for whether they would like to be delivered by a doctor or a midwife, whether they want natural childbirth. They want to learn the opportunities that they have for the different choices.
Okay.
Every now and then you hear the term high-risk pregnancy. What does that mean? And how are these pregnancies identified, monitored, and brought to a successful conclusion? So spend a little time. What's a high-risk pregnancy? How do you monitor it, and how do you?
High-risk pregnancy is the pregnancy which has certain potential to be complicated by maternal or fetal condition. They can lead to not the best outcome. It means the baby could be born prematurely, the baby could be born with certain congenital problems, and the mother also can suffer complications related to her medical condition.
Well, let's come back to this because I think it's very important. But before that, we have Kim. Kim, you have a question for us.
Yes.
Are you there?
Excuse me?
Okay, let's continue with our high-risk discussion because I think it's important.
Okay. The main high-risk problems is that women can have medical problems complicating pregnancy prior to the pregnancy, and that those medical problems need to be optimized prior to the pregnancy.
Maybe
Ideally,
you tell us a list of some of these medical conditions.
If a patient has high blood pressure, if she is a diabetic, if she has any chronic medical problem, if she has lupus, if she has any major medical problem, that should be spoken to with her obstetrician and her primary care physician who's taking care of that problem prior to. There are medications that a patient that has a seizure disorder should not be taking when they are pregnant. So these need to be planned for during the pregnancy. The other high-risk pregnancies are obstetrical indications for being high risk, and those are dealt with on labor and delivery in the high-risk clinic that we provide.
Simply, if somebody was pregnant before and the pregnancy was complicated with any abnormalities, you can expect that the next pregnancy
it will not be easier.
That will be easier. So this patient should be in the high-risk clinic to be monitored and be sure we do everything possible to avoid the complication that already happened during the previous pregnancy.
Okay.
Now, moving from the high-risk pregnancies to normal pregnancies, what is the typical length of stay for a pregnant mother after delivery, And what is the type of staff that is involved in caring for that mother?
During her stay, during her labor, during her labor and delivery stage,
Yes.
she will be taken care of by a member of the staff, the nursing staff, a midwifery patient, or a doctor patient, or together.
Right.
There will be attending physicians and resident physicians caring for the patient. And then after the delivery, the patient is usually asked to stay and bond with the patient during a normal delivery. The baby is kept with the mother for as long as the mother would like.
Just 1 second. Anna, are you on the air?
Yes, I am.
Anna, do you have a question?
Yes. My question is, are there any negative effects regarding taking birth control over a long period of time?
Good question. You heard the question.
The birth control happened to not be part of our obstetrical care, because sometimes, of course, we're prescribing the birth control after delivery. What we know...
No. Suppose an 18-year-old or 20-year-old has been taking birth control pills and now she's pregnant at 26.
Oh, if she's pregnant and birth control, no.
26.
That should not be any...
No. If you're taking birth control pills before you got married,
Okay.
and now you're deciding to get pregnant, and
Does
you
it
have been
create any obstacles for the pregnancy?
No, should not be any problem for the pregnancy because somebody was on birth control pill. Of course, there is some complication taking birth control pill, and everybody who takes the medication can read the label and knows that in rare circumstances the patient may have increased tendency for the blood clot formation. But if we're talking about the statistics,
Right.
unwanted pregnancy,
Yeah.
it's much more dangerous and create more complication than complication from taking.
So
birth
the short answer is birth control
not affect
pills
the,
are not
not
going to
affect
affect
the pregnancy.
Yeah, I'm sorry, Dr. Marai. Thank you very much, Anna.
Okay.
So the patient that has a normal delivery
Right.
will be transferred to our postpartum floor and then usually spend 2 days with us, learning to take care of the baby, getting help in breastfeeding if she wishes to do that. We have a breastfeeding counselor, okay, and getting ready to take the baby home.
Do you ever let patients go home within 14 hours if they want, after their second baby or something like that?
The hospital will request that the baby stay for longer than that,
Right.
but the mother could.
Mother could go.
Just to go back to what Dr. Gomes was saying earlier, the length of stay for a high-risk pregnancy, how many days would that be? And
If she successfully has a normal delivery, and many of our patients that are high risk do get induced in their labor, so the induction part usually takes a day, and then if they have a normal delivery, they stay the same number of days
Right.
as a normal person, except if there are other complications. If someone is hypertensive
Right.
and needs hypertensive medications and needs follow-up in one of our primary care with one of our primary care physicians for her hypertension, we
Right.
may include them in our care
I see.
of the
Many
high-risk
patients are more concerned about pain than anything else. How do you reassure our patients who are listening, or potential patients who may be listening, about pain in pregnancy and pain in delivery? Touch a subject.
I just mentioned this before, that in the 21st century, every patient should have as painless delivery as possible.
But what's the reality?
The reality is everybody who qualifies for epidural anesthesia can get epidural anesthesia. Everybody who, for whatever the reason, would like not to have general anesthesia can receive different medication. They're going to take pain away. And the only, of course, problem is that there has to be indication. Otherwise, some patient may have long-lasting discomfort prior to going to deliver, and those patients may qualify for medication for pain, but of
Right.
course nobody will start anesthesia 2 or 3 days before actual delivery.
But you're trying to reassure the patients
Everybody-
that it should be pain-free.
Absolutely.
Okay. Dr. Mali, you agree with him? Or
Patients will request different things. Pain in labor can be expected, and if you want natural childbirth and you want to have Lamaze classes, and you want to use other techniques to take away your pain, such as using the bath.
That leads right into Mr. Schneer's question.
Which is really, what makes the Bronx Lebanon birthing experience unique in comparison to other hospitals?
We have a gamut of people that are there to help you in your labor process. And one of the things that we do offer is you can labor in a tub. So
in a whirlpool delivery.
In a whirlpool delivery tub.
Right.
And that does help in taking away such pain.
Right.
I would just add something, that what is unique is the structure of the Bronx Lebanon OB service. We are not fractioned between obstetricians, pediatrician, anesthesiologists, but what is absolutely unique, the neonatology unit and the anesthesia units and the OB units are creating one unit. It means we're all working together, so definitely it helps the patient to be taken, help us to take care of the patient.
Everybody is always there.
Everybody's always there, everybody's communicating. Yeah. So that makes the whole process much easier.
So with your outpatient services also located in the same building,
Absolutely.
It's a one-stop shopping approach, if you will.
Yes.
Okay, at this point, let's pause for a short break, and when we return, we will continue our discussion, as well as also take calls from you, our viewers. Once again, the number to call is 718-960-7241. That's 718-960-7241, and please call us.
Okay, so far so good.
Bronx Lebanon surgeons are experts in the field, bringing a diversity of skills and cutting-edge operative procedures to their patients.
But what is most important about our Bronx Lebanon surgeons is that they are responding to many difficult challenges and saving lives.
Nurses at Bronx Lebanon are also an integral part of the OR team.
We work with the surgeons in the operating and recovery rooms and are at the patient's bedside providing the necessary support and compassionate care.
In the ICU, our critical care specialists evaluate, treat, and monitor patients until they're strong enough to be transferred to a med-surg floor.
Sometimes surgical measures are necessary to breathe life back into patients, and ear, nose, and throat surgeons are called into action. Bronx Lebanon's oral and maxillofacial specialists are widely acknowledged for their expertise in all types of dental surgery.
From tooth extractions under intravenous sedation, the emergency treatment of facial injuries, to innovative implant procedures, we are clearly placing smiles for miles in the Bronx.
Bronx Lebanon is also leading the way in cardiology, dermatology, internal medicine, infectious diseases, neonatology, nephrology, neurology, pediatrics, family medicine, pathology, psychiatry, and radiology. And its Bronx Care Network, including a soon-to-be-completed ambulatory care facility, is fulfilling the hospital's essential role as doctor to the community.
Welcome back to HealthBeat. We come to you live on BronxNet every Monday evening from 6:30 to 7 p.m. Please call us at 718-960-7241 with any questions you may have, and we will certainly do our best to answer them. That's 718-960-7241. Now let's continue our discussion. Now, we often ask our panelists to share their respective backgrounds with our viewers, and I'm sure both of you have some interesting backgrounds. Let me start with you, Dr. Reese, particularly in terms of what interested you in the field, as well as also share your schooling and what your credentials were to get to where you are right now.
Okay, that will be a long story. It's almost 40 years since I graduated medical school. I graduated medical school in Poland, and then I went to the residency program, fellowship in obstetrics. I did my PhD in obstetrics, which is the way it's in Europe the training goes. And then after leaving Poland, I stopped shortly in Vienna, in Austria, and then coming to United States, I went again to the full training. I was director of obstetrics at Wyckoff Hospital. I was director of fetal testing at Jacobi Hospital. I work in Einstein, Montefiore, North Central Bronx, and almost 15 years since I came to Bronx, Lebanon. My major interest always was preterm delivery. And in our patients, with our patient, this is one of major problems. Because as many people know, that preterm delivery is a major reason for mortality, morbidity of the newborns. Unfortunately, we still don't have anything to eliminate the preterm delivery. There is nothing effectively prolongs labor in sense of stopping the contractions, but we have certain medication and certain techniques which can at least prolong the pregnancy or make the baby more prepared for delivery so they don't suffer complication, which major will be inability to breathe properly and die or suffer brain damage as a result of inability to oxygenate the brain. That will be the of course we deliver and care to patients with many multiple problems, but that will be probably one of our major concerns.
Right. And Dr. Marta, how about yourself?
I am a New York boy. I grew up in Queens. I went to NYU for college, and when it was up in the Bronx, the uptown campus, and then I went to medical school in Mexico, and then worked at Queens Hospital Center for 30 years, and then recently, 5 years ago, came and worked at Bronx Lebanon Hospital. I was director of obstetrics at Queens, and then I am director of maternity services at Bronx Lebanon, and got into the field, I guess because I'm selfish and wanted instant gratification, because you go into labor and delivery, you meet a patient, and you help them through their labor, and out comes a newborn baby. So it was very rewarding.
Okay, what's a typical day like for both of you? You can tell us.
It's changing year by year, but recently we both creating a team covering labor and delivery between 8 a.m. and 5 p.m. And this is the time when we're taking care of the most complicated cases, all the difficult repeat C-sections are being done, patient with certain complications are being delivered at that time. And of course, from time to time, we have to also come at night and take care of the patient who has major problem.
I think last Friday you all were there at night.
Yes. We were last week we were at least two times late taking care of the patient.
Your day is like that, or
yes, we share duties on labor and delivery. Our triage area on labor and delivery is always hopping with patients coming in with problems earlier in pregnancy, and then patients coming in to be evaluated for labor.
Right. Now, what types of educational programs are available for women in our community, and how can individuals access these services at Bronx Lebanon?
Every patient who enters the prenatal care at the Bronx Lebanon Hospital has a chance to enter Lamaze class and be fully educated about the process of procreation, which involves everything from the beginning of pregnancy to the delivery.
Is Lamaze still popular?
We offering everybody, and I personally believe it's very, very helpful because...
but you didn't answer my question.
It's a popular... I don't think we're seeing so many patients entering the program that we used to see years ago. And I really don't know with the people learning about labor and delivery.
Epidural?
Maybe. And the epidural may be the fact that the people are now trying to make the whole thing much easier for themselves. And Lamaze class requires dedication and time. And but we have something else also run by our midwives, which is the group prenatal care, which is also a very interesting concept, when instead of spending 15 minutes with one provider once every 2 weeks, the patients are getting together every week, and they're listening to the teaching, they're exchanging information about the pregnancy, and of course everything private things is being still done on the side.
You want to add anything about the...
Well, we also have a teen program for teenagers that want to be taken care of together with other teens, besides the centering program.
Another question that I hear about quite often is, when are cesarean sections necessary, And what is the percentage of deliveries that is associated with cesarean sections? What's the number? What's the number that's reported out there? What's the valid number of cesarean sections that are not scheduled?
Unfortunately, nationally, the number of C-section is growing year after year. And I don't know, of course, the data from the last year, but it was well over 30% nationally.
That's high, isn't it?
It's high, but it comes from the belief that C-section, modern time, when there's excellent anesthesia and good care of the patient, in certain situations may be safer than those prolonged deliveries we used to have 30, 40 years ago. Unfortunately, with the increasing number of C-section, we're dealing with increasing number of patients who previously went to the C-section. And then this probably is one of the reasons why the numbers keep growing up. Because someone who has a previous C-section very often
we'll get another one.
Is getting another one as a choice, because that's the way the patient can act and request the repeat C-section, or because of the failure of another delivery. So I don't know what we can do to reduce the C-section rate. As long as the patient are safely delivered, and as long as the patient understand that the C-section cannot be repeated endlessly, the situation could be controlled.
Right. Now, on another note, we often ask our panelists, and I'll start with you, Dr. Marta, to share their respective success stories with our viewers.
We have, together recently, in 1 week, both delivered very premature babies. And
what does that mean?
One baby was 24 weeks pregnant, and the other woman was 24 weeks pregnant, and the other was 25. Right. And we have successfully had, those babies are still doing well in the intensive care nursery.
Wow, that's terrific. Dr. Gums?
What are your recommendations for women that are having difficulty conceiving?
Another area of gynecology is called reproductive endocrinology, and they first must see one of our primary care people, and basic tests will be done, and then they will be sent to a special clinic, an infertility clinic, to try.
But we have that.
Yes.
Yeah.
Dr. Reese, what is the ideal length of a pregnancy, and when should a pregnancy be induced?
Okay. For many, many years, the so-called post-term pregnancy was calculated as a pregnancy which will last more than 42 weeks. The concept was based on the statistics. It means if somebody was pregnant over 42 weeks, there was an increased risk for the baby to die in utero.
But that's not true anymore, is it?
It's not only true because now we started delivering the babies earlier. And in the last couple of years, we inducing labor if the patient reaches 41 weeks gestation.
Right. And on that note, let me thank both of you, our panelists, Dr. Marta and Dr. Reese, for joining with Dr. Gums and myself on tonight's HealthBeat television program.
Thank you for inviting us.
And most importantly, let me thank you, our viewers, for tuning in this evening. You will continue to be a most important part of our HealthBeat television program.
In the interim, if you